Hey everyone, welcome back to OT Rex. Today's video is going to be about hip precautions, and I have another OT here with me. And if you have seen some of my other videos, you have already gotten some words of wisdom from her. So, we're going to talk about what a hip fracture is, what the surgery is like, and most importantly, cover the post operative precautions that OTs usually have to educate patients on. What causes a hip fracture? So I always like to go over an overview before I dive into how OTs are going to help a patient. We need to know what they are experiencing and what they have gone through to get an idea of why the precautions are there. So we have a ball and socket joint between our femur and our pelvis, and we have a cushion of cartilage in between. Typically, they have a type of arthritis, so it can be rheumatoid arthritis or osteoarthritis. So it could be wear and tear as you age, or for rheumatoid, it's the disease of the cartilage thinning out is going to cause rubbing between the femur and the pelvis, and it's very painful. So that can happen. You can also have a trauma, such as a fracture or an injury to the hip joint. There are other reasons why someone might need a hip replacement, but these are kind of the main ones that I come across. Does a person need surgery? Typically, you will need it when there's a loss of function, so there's decreased independence in our ADL, or there is a lot of pain. So, those are the main reasons. And then surgery is really interesting to me. I think I just really like learning about the process. What they do is they cut the ball of the femur bone and then they smooth out the socket and then they cover it into a metal backed component. And then they join the two together with screws or some kind of special cement. Now we're going to dive into post-operative care, and this is when I'm going to ask my OT friend who's joining me to give us all of her advice and her tips and things that she's learned along the way working in a skilled nursing facility. Before I get started, typically we see hip patients in acute rehab or inpatient settings, so hospital settings, as well as skilled nursing facilities once they are, stable enough and they transfer over. Oftentimes in skilled nursing facilities, the patients have other needs as well. So you'll find that those complexities might get in the way of how treatment flows. But recovery time, as in how long the patient has to follow hip precautions and protocol, is for 3 months. So this is a pretty long time. Let's start with the two types of approaches. So we have an anterior and a posterior approach for surgery, right?
Yep, that's right. And for the anterior hip precautions, it would be don't bend your operated hip past 90 degrees, don't extend your leg behind you, don't cross your legs, and do not turn or rotate your leg outwards. And for the posterior hip precautions, it's kind of the opposite. You can't bend your operated hip past 90 degrees, and you can't cross your legs, but you don't want the patient to turn their leg or rotate it inwards. So sometimes you can tell the patients, keep your toes pointed up to the sky when they're in bed, or if you're walking with them, you want to tell them to keep their toes pointed forward.
Gotcha.
So that they're not rotating it. Mm-hmm.
And between the two, which one is more commonly used?
The posterior approach is more commonly used in my experience. The anterior approach, I haven't really worked with many patients that had anterior hip precautions.
For those of you who are studying, we are just sharing the differences between the anterior and the posterior approach because I think that it still shows up in a lot of our study guides and textbooks that OTs study off of. So it's just good to know that there are two different kinds. So I'd love to hear your experience on working with patients with hip replacements and what that looks like in real life because we have these precautions that we are memorizing and we know to do, but how do interventions and like treatment typically go when you're working with these patients?
Oh, okay. So first, when we start with the evaluation, you have to do a chart review. And in their chart, it's usually indicated whether they had a anterior or posterior approach, and the weight bearing restrictions of how much weight they can put on that surgical leg or that leg that just had surgery.
Mm-hmm.
So it'll the weight bearing restrictions. It could be non-weight bearing, which would be 0%, toe touch weight bearing, or toe down weight bearing, where you can just kind of put a toe on the floor.
Right.
Partial weight bearing, and usually the surgeon will tell you what percent of your body weight you can put on that leg.
Mm-hmm.
We also have weight bearing as tolerated. So you can put your full weight down, but you would just kind of have to gauge the patient's level of pain and go from there. Once you do the chart review and you go to evaluate the patient, you also want to get an idea of their cognitive level to see if they are going to be someone who can remember those precautions, or you might have to really drill them because they might not always remember, or if they're in a different position, like they're in bed, they might not realize like bringing their knee to their chest is still bending over past 90 degrees. So you might have to just provide patient education there to let them know that that's not something that you want to do.
Mm-hmm. I think the patient education part is so important for hip precautions because we only see these patients for what, like 30 minutes to maybe an hour in the day. And think about how many times that they are going to break their precautions when we aren't there to really tell them to correct their posture or positioning. So, also coaching our caregivers, our family members, the nursing staff, if they're unfamiliar, is a really good way to work together to make sure that they aren't breaking those precautions.
I've had patients that have memory deficits, and when I go to treat them, like when I go to their room, I would always ask them, can you repeat your hip precautions for me, and go through them again before I get them out of bed and start moving. Sometimes I would make a goal, like the patient will be able to verbalize 2 out of 3 of their hip precautions independently, so
Awesome.
that they really take accountability.
What else do you guys work on to support self care? Is it mostly the precautions and the adaptive equipment? Is there anything else that you've come across that you wanted to share?
Well, let me see. For patients who have had hip surgery and have certain precautions, we would definitely work on bed mobility. You check their pain level before getting out of bed. And if it's fairly low and they're willing to work with us, we will try to get them out of bed on the side that they have not had surgery and kind of go from there. During self care, such as donning your pants, we would provide the reacher so that they can use it to initiate their legs through without bending past 90 degrees, of course.
So that concludes our overview for hip precautions. Thanks so much for watching, guys. I hope that this was insightful. And I plan on making one for back precautions as well with our special guests. So stay tuned for another video, and